We have a nice full house tonight, so it's great to see everybody. I am Melinda McIntyre. I am the Vice President of Operations for the Heart and Vascular Service Line for WellSpan Health. And I will first start out by introducing my dyad partner, Dr. James Harvey. James, can you wave to the crowd? James is the Chief Medical Officer and Vice President for the Heart and Vascular. And and apparently we're giving hugs. I want to first start out by thanking the team of people that put this together. This is a big undertaking, and so thank you to all of you who have been here setting up and participating. And we'll start with the Diehl Lectureship is sponsored by the Millard G Diehl Cardiovascular Lectureship, started in 1996, so 30 years. It was a generous gift left to WellSpan Health by Mr. Diehl, and we have some of the Diehl family here tonight, so let's give them a round of applause for their sponsorship. So what this gift did is it created an endowment to allow for long-term support for an annual educational program, which is why we're all here this evening. It's to serve both our community and our healthcare professionals. It reinforces WellSpan Health's commitment to education and knowledge sharing. And it gives us an opportunity to get with all of you and talk about all things related to the heart and patient care. So this is a wonderful legacy that Mr. Diehl has left for us, and we appreciate it very much. Tonight you get the distinct pleasure of having two of our physicians that work for WellSpan, and I'm going to introduce the two of them. Dr. Norton, if you can wave to the crowd. Dr. Norton is our WellSpan Lebanon cardiology practice provider. He did his cardiology and interventional cardiology training at Penn State Hershey Medical Center. He is the proud father of 4 children, and in his free time, he enjoys cycling and trail running. So we'll be excited to hear about that. And then Dr. Langston, Matt, practices in our Lancaster Ephrata practice. He grew up in central Pennsylvania. He attended Gettysburg College, then Penn State for graduate school, went to the University of New England in Maine for medical school, followed by his fellowships in cardiology and interventional cardiology at Christiana in Delaware. And he is the proud father of 1 daughter who has graced us with her presence this evening. And in his free time, he has been very unsuccessful in keeping pace with Dr. Norton's cycling endeavors, despite his best efforts. So there's a little bit of competition there. And James and I also wanted to add, these 2 physicians that you're going to have the distinct pleasure of hearing tonight have really greatly increased the interventional care that we provide to our patients in the East region, and so we want to give them a round of applause and say thank you. And with that, I'm going to hand it over to Dr. Norton. Thank you all.
All right, well, thank you all for being here. I'm really excited to talk. So we're going to talk about pulmonary embolisms. So this is something that we offer more care for at Good Sam than we used to, so I thought this would be an exciting topic to present. To get us started, I'd start with a case. This is a case that we had at Good Samaritan Hospital recently. So this is not the patient's real name, but we'll call him Mr. Smith. He was a 68-year-old gentleman. He came into the ED with a 7-day history of shortness of breath that was worse in the 24 hours leading up to him coming in. His medical history was significant only really for renal cancer. When he came into the ER, his vital signs demonstrated that his oxygen levels were low. He actually required some supplemental oxygen. His heart rate and blood pressure were both normal, but he was breathing very fast. He was tachypnic. His heart rate was, his respiratory rate was 28. He had no fever. His blood work was significant for elevated BNP and troponin. His EKG was pretty unremarkable, just showed sinus rhythm with an incomplete right bundle branch block. So let's talk about pulmonary embolism. So PE is a sudden blockage in one or more of the major arteries in the lungs. This is potentially life-threatening, and it can be an emergency because this blockage prevents blood from reaching the rest of your body and puts a significant strain on your heart. A DVT, or a deep vein thrombosis, is a blood clot found in an extremity. Most PEs occur because these blood clots in the extremities will actually travel through the veins in the pelvis, back through the bloodstream to the lungs to create this blockage. This is important. PEs represent the 3rd leading cause of cardiovascular mortality following myocardial infarction and stroke. And what's interesting is the presentation for PE can vary greatly, anything from no symptoms at all to sudden death. There's many risk factors for people to develop pulmonary embolisms. One of the major ones is immobility. So people who are lying in bed or not moving as much, people who are traveling long flights is a good example, bed rest maybe from a surgery, or laying in a hospital bed. Surgeries create damage to the blood vessels, which can increase inflammation and also put you at risk for blood clots, especially like orthopedic surgeries or trauma. And then there are certain conditions like cancers, heart disease, or blood clotting disorders that can also put you at risk. Also, hormones are important. Pregnant women, postpartum women, or being on hormonal therapy can also put you at risk for pulmonary embolisms. What do people complain of? The most common symptom by far is sudden onset, unexplained shortness of breath. The medical term for that is sudden dyspnea, and that is by far the most common symptom. And that's followed by chest discomfort or maybe even cough. Hemoptysis is actually coughing up blood, and that also can occur when the lung starts to die. People also can complain of leg pain or leg swelling, and that's because of a potential blood clot in the leg or the arm. Patients can present and look very normal. They can also be breathing fast. That's called tachypnea. Their heart rates can also be elevated. Their oxygen saturations may be low, as in our patient that we described in the ER. And then I also already kind of described hemoptysis, which is the coughing up of blood, which occurs rarely but can be seen. So back to our patient in the ER, Mr. Smith. His imaging, his chest x-ray was normal, did not have anything acute. He did get a CAT scan of the chest, which we'll go over, and that showed that he had extensive clot in both lungs with evidence of RV dysfunction. So the right ventricle is the part of the heart that pumps blood to the lungs, and that was abnormal. The ultrasound of his leg showed no clot, no evidence of a DVT, which was interesting. And then his echo showed that the right side of his heart was severely abnormal. I think it's important to talk about the severity of pulmonary embolisms. So this helps give us a framework of how to treat these patients. So high-risk PEs are those defined by anyone who comes in because they had a cardiac arrest. That automatically puts you in a high-risk category. Also, blood pressure is important. So people who have low blood pressure because of the pulmonary embolism puts them at high risk. We define that as the systolic blood pressure being less than 90 or a drop in 40 for greater than 15 minutes. This has a very high mortality or death rate, ranging in big studies from 15 to 52%. Interestingly, the treatment classically for this is clot buster medication to actually break up the clot, but only about 16% of people receive this because that clot buster medication also has a lot of risks to it. Intermediate risk pulmonary embolisms, also known as submassive PEs, are basically those that don't meet those hemodynamic criteria, but they have evidence of what's called RV strain, or that right side of the heart not functioning as well as it should. And then low risk patients are those in neither of the other categories. Some features that kind of tell you that this is a high risk would be patients who pass out. That's kind of a high risk feature. Also, like mentioned, low blood pressure and evidence of RV strain also, make you think that this is a high risk feature. Testing that can be done in the ER. So the gold standard test is a CAT scan of the chest. This is where we inject dye through a vein, and this kind of highlights the clot. And we'll go through some images that'll kind of show you what this looks like. Blood work can be important. There's something called a D-dimer that can help rule out a PE. There's also other tests, like I mentioned, that troponin test or the BNP, which can indicate that there's injury to the right ventricle, which tells you that it's putting a strain on that side of the heart. There's other scans such as a VSQ scan, which is like a nuclear study to look at perfusion of the lung. And then, like I mentioned, the EKG and the chest X-ray can sometimes be helpful. So this is a cross-sectional image of someone's chest who has a pulmonary embolism. So if you look at image A, there's a blue arrow. Hopefully you can see that. That's a dark spot in something that's white. That white area is actually the pulmonary artery. And it's lit up white because that's where the contrast is that we give through the vein. And that dark spot is the blood clot. And you can see that again in image B and image C. In image D, in the bottom right-hand corner, I have a blue arrow pointing to the right ventricle. That smaller kind of half-moon structure below that is the left ventricle. And normally the left ventricle is the same size, if not bigger than the right ventricle. And here you can see that the right side is actually much larger because of that strain from the clot in the lungs. There's a term called a saddle embolism. This is where the pulmonary artery kind of splits in two to go to each side of the lung. And this is where the blood clot sits, where that blood is splits, and it sits like a saddle at that bifurcation. And that's called a saddle embolism. And you can see how the blood coming into the lungs could be obstructed by that, and that can cause low blood pressure and all those symptoms we talked about. So how do we treat PEs? We usually, the standard of care is to use medicines like blood thinners. If patients are going to undergo a procedure for the blood clot or lytics are considered, we usually start with heparin, which is a medicine that we give in the hospital. When patients are ready for discharge, we usually move them to like an oral medicine, and we usually do that for a period of time, usually months. Clot busters like Activase or Alteplase or TPA are medicines that actually break up the clot, and those are usually only indicated for severe or massive PEs. And then there's procedures like pulmonary embolectomies where we actually can actually aspirate or suck out that clot that's in the lungs. And then there's also therapies like catheter-directed lytics, which actually break up the clot in the lung, and there's even surgery that can be done as well. A preventative procedure is something called an IVC filter, where we actually put a filter in one of the veins in the leg, or excuse me, in the belly even, and that helps prevent the clot that's in the legs from traveling to the lungs. So let's go back to Mr. Smith. So this is his CAT scan. This is the WellSpan Good Samaritan Hospital. In the ER, it showed that he has a saddle PE, so he has blood clot sitting at that bifurcation or that splitting in the pulmonary artery. We know that's a high-risk thing to have. This was his echo that we did the next morning. So you can see that his right ventricle, which is highlighted by that blue arrow, is large. And that red arrow shows his left ventricle, which I said is supposed to be about even bigger than the right ventricle. And you can see here it's actually smaller because there's so much strain on the right side of the heart. So the following day, we did a thrombectomy procedure, and we removed clot from his right lung, left lung, and even the main pulmonary artery. His baseline pressures in the lung were elevated at 39, and then following the thrombectomy, it was actually normal at 18. This is a real picture. I'm glad you guys already ate, but this is the picture of the blood clot. I snapped this with my cell phone. So this is the real clot that we took out of his lung. So that's just kind of what it looks like on a piece of paper. So I just wanted to go briefly over a couple trials of why we would consider using a catheter to get clot out of the lung. There was a trial published in 2021 in the Journal of American College of Cardiology called the Extract PE trial. They looked at the RV, which is the right ventricle, to the LV, or the left ventricle ratio. And this has been classically a surrogate marker for mortality in PE patients. And they showed a significant reduction in that ratio, which is a positive thing, with thrombectomy compared to just the oral pills or the anticoagulation alone. There was another trial called the FLAME trial. This was published in Circulation. This looked at the Inari flow retriever device, and this showed that this reduced in-hospital mortality and adverse events in patients with high-risk PE. In fact, it was so positive that they actually stopped the trial early because of the benefit in these high-risk patients. The Peerless trial was published, I guess, about 2 years ago now. This was a randomized trial looking at two different forms of catheter-based treatment, catheter-directed lytics versus mechanical thrombectomy. And it showed that mechanical thrombectomy had significant improvement in like bailout, emergent procedures, ICU stay, and had a similar safety profile. The STORM PE trial demonstrated that adding thrombectomy to anticoagulation resulted in earlier physiologic recovery, a decreased RV strain, and better 90-day functional outcomes, like a 6-minute walk test, compared to just anticoagulation alone, and was considered safe. The STRIKE PE trial is an ongoing trial. Preliminary data is just showing, again, very positive. The RV to LV ratios are improved. It's a safe procedure, and patients tend to feel better. So our case, Mr. Smith, he did experience immediate improvement after we did the thrombectomy. His shortness of breath resolved actually almost hours after. He was weaned off of the oxygen that he was put on in the ER the same day that we did the extraction of the clot. His echo was still abnormal. It usually takes weeks to months even for this right ventricle to recover, but it did show some improvement even the day after the case was done. And then he was actually discharged home within 24 hours of doing the case. So how do we prevent these things? Well, early mobility after surgery is probably the key. Regular ambulation or regular walking is very important. Movement during traveling or illness. And then sometimes we actually give patients anticoagulation to prevent blood clots if we know that they're going to be at higher risk. Maybe you're getting a knee replaced or something like that. Sometimes we consider putting people on blood thinners prophylactically, especially if you have a history of clot. And then it's important to have multidisciplinary follow-up. It's really important for patients to follow up with primary care doctors and even consider referrals to subspecialists like hematologists, pulmonologists, and cardiologists. So in summary, PEs are most often caused by blood clots in the legs, and they're actually considered a medical emergency. The presentation may range from no symptoms at all to sudden death. Most commonly, patients experience sudden shortness of breath or chest pain. All patients are treated with anticoagulation, and intermediate or high-risk patients should be considered for catheter-based treatments. So that's all that I have. So I'll pass it over to Dr. Langston. Yes, Dr. Harvey. Yeah. Yes. Yep.
You said thrombectomy. It sounds like you took the clot out of this person's lung.
That's right.
Did you open the chest to do that? How did you do
No, that's a great question. So we actually, we go through a vein in the leg or the neck, typically the leg, and we put like a little plastic tube, which is like a hollow straw, up over a wire into the lungs, and we can actually use dye in the lungs to see where the clot is, and then we actually suck it out from there. So there's no scalpels, there's no cutting, just catheters through blood vessels. Yeah, that's a great question.
Do you have to go through the heart to get into the lung?
Yes, you do. Yep, that's a great question. Yep, you have to go through the right side of the heart. Yep.
But not through the wall. Through the
Yeah, that's true. Yeah, not through and through. Yep, through a side of the heart, I should say. Yeah, that's a great question.
We will filter questions for the end, so if you have it, just maybe write it on your notepad, just so that we stay on track. Yeah, Dr. Harvey, maybe he just blew it up for us. But hopefully you got to see some of the devices at the back, which I thought was really cool. I'm sorry, Aubrey, you missed it. My kids loved it last year when they got to suck the clots out, so maybe next year.
Awesome. Thank you, Dr. Norton. I appreciate you speaking. It's interesting. Dr. Norton and I shared our time in training at Christiana together. He was a year ahead of me, so I continue to follow him. Someday I may get the upper hand. You know, Samantha asked us what we wanted to talk about. I am relatively new to the WellSpan system, only have been in the system for a couple months now, and I reflected on my short time and I said, you know, I don't get to play with the fun toys like Dr. Norton does, so something that I see every day, aspirin, and that's something that I feel is important. So today I'm going to speak with you about aspirin updates for cardiovascular prevention. I have no disclosures relevant to today's procedure. So oftentimes we're asked to give these presentations, but it's given by people who have decades of clinical experience, so I appreciate the opportunity to be able to speak with you guys today. So as I go through these talks, I often ask myself a variety of questions that help frame the outline for this. So I'm excited to share what I found today with you. So we'll start with what is aspirin. We'll review its role in blood clots. We'll weigh the risks and benefits of the medication itself. We'll detail some of the early trial data supporting its use, and we'll talk about where we are now for the primary prevention in coronary artery disease. We'll examine some of the adjuncts that we have for ischemic versus bleeding risk stratification, and we'll take a look at some secondary prevention in patients who have had events. We'll finish up with some take-home points, and then we'll get to the questions, which hopefully there will be a few of. So what is aspirin? Aspirin is a Swiss Army knife of medications. It's used for a variety of indications, commonly pain, fever, inflammation relief. Today we're going to be focusing on its antiplatelet effects. It is the 46th most common prescribed medication. I had to look that up, but I think that's underestimated because it's a very common over-the-counter medication as well. Historically, there's some data dating back to 400 BC that it was found in willow leaves, but its synthesis was identified in the 1800s in 12 simple steps. And anybody who's taken an organic chemistry class has probably made this. It's very easy medication to make. It was trademarked by Bayer in 1899, a German company. It didn't take us until the 1970s to finally clarify what its mechanism was in us. That is the inhibition of the COX-1, the cyclooxygenase 1 enzyme that blocks production of prostaglandins and thromboxane, ultimately interferes with blood clotting. This earned Sir John Vail the 1982 Nobel Prize and ultimately ended up the FDA approval in 1985 preventing recurrent heart attacks. So taking a step back, platelets and coagulation. There are three main things in the blood: red blood cells, white blood cells, and platelets. Whenever there's damage to those blood cells, to the vasculature, to the vessels that bring those nutrients and those cells around to the body, platelets and those things respond to form blood clots ultimately. I know this is a little bit complicated, and my wife told me I should probably not put this in, but it illustrates a couple important points about where aspirin acts in the body. So there's three kind of mechanisms that platelets achieve in the body. They adhere to the site of injury, they activate themselves and activate other platelets, and then they cause more platelets to stick in those areas. Aspirin interacts with the thromboxane A2, which blocks that activation of other platelets. And I illustrate this because I wanted to clarify some terminology which I think exists in a lot of the patients that I see regarding anticoagulation, aspirin, and antiplatelet agents. Excuse me. Anticoagulation agents work in a separate area of blood clot formation. They work but a little bit lower down in an area called factor 10. These medications include Eliquis or apixaban, Xarelto, rivaroxaban, or Coumadin and warfarin. These are different than other medications called antiplatelet agents, which also work in a different area higher up, similar to where the aspirin acts on platelets themselves. These medications are like Plavix or clopidogrel, Brilinta or ticagrelor, and Effient or prasugrel. So I wanted to clarify that these are different medications, and they have different indications for different pathologies. Other abbreviations that I'd like to clarify as we go through: ischemic events, heart attack, myocardial infarction, stroke, things that cause blockages. Bleeding events, most commonly gastrointestinal or intracranial bleeds. MI is myocardial infarction, heart attack from a blocked artery, most commonly due to a plaque rupture. ASCVD, or atherosclerotic cardiovascular disease, heart attack, myocardial infarction, stroke, coronary carotid artery disease. Primary prevention, things we do before an ASCVD event, secondary prevention afterwards. ACS is acute coronary syndrome. Those involve things like ST segment elevation MIs or STEMIs, non-STEMIs, as well as unstable angina. DAPT refers to dual antiplatelet therapy, aspirin and another antiplatelet agent like those P2Y12 inhibitors we mentioned before. They're used to protect those stents while the body heals. And MACE is typically a trial outcome standing for major adverse cardiovascular events, typically death from any cause, myocardial infarction or stroke. So should we fear those bleeding events or the ischemic events more? And I think the answer is yes, we should. Anytime we initiate these antithrombotic therapies, we're weighing the risks of ischemia versus bleeding risks, and we have to account for patient characteristics, the clinical presentation, comorbid conditions, other medications they're on, as well as procedural aspects. Both bleeding and ischemic events influence survival. This was a trial from 2009 that looked at post-ACS patients and showed that there's an early risk to heart attacks that fades over time, but the bleeding risk, the major bleeding risk, persists even at a month. So yes, we need to consider both of these in our therapies for our patients. Everything has side effects. There's risks of doing things. There's risks of not doing anything. Aspirin's side effects are primarily gastrointestinal and dose-related. There's a direct effect on the gastric mucosa, causing erosions, ulcer, bleeding. We've sidestepped some of that with different formulations like enteric-coated or liquid formulations. Our pharmacists have restricted the IV versions to pediatrics. We also need to be careful of other medications that interact with those same receptors like ibuprofen or naproxen, ultimately reducing the cardioprotective effects of aspirin. Patients can have allergies, respiratory, skin, systemic sensitivities, and we have monitored protocols that we can desensitize our patients. One of the favorite questions I'm asked is, well, do you know the side effects? Have you seen the side effects? Have you read about this? Well, yeah. Aspirin's is 59 pages long, but it's actually one of the shortest ones. Atorvastatin, one of the higher medications, is 65 pages long. So there's risks of everything. And we have to acknowledge that when we use these medications. So how did we get to where we are today? I'd like to take a quick lap through a couple of the trials that we have for these. Now, these are primarily based in the ACS patients, or the patients who have had acute coronary syndromes. That's who we initially studied. The first trial on your left is from 1979. While there was no statistical benefit of aspirin, it suggested that there may be a role for reducing mortality in ischemic heart disease. The next major trial that came out on your right, 1983, was the VA cooperative study, and was the first study that showed definitive benefit that aspirin decreased the incidence of death at 51% in patients with ACS. The next trial, the Canadian study, confirmed that at a dose of 325 milligrams 4 times daily that there was indeed benefit. That's a lot of aspirin, and that's going to come with a lot of side effects. The RISK study actually established low-dose efficacy. Now, they dropped the dose to 75 milligrams. Now, we're going to talk about differences in the doses. When we talk about baby aspirin, we typically mean the 100 milligram, 81 milligram, or 75 milligram dose. Now, those are just based on whatever country you came from. Bayer, a German company, had the rights initially, made 100 milligram dosing. If you're in the UK, It's 75. If you're in the US and Canada, it's 100. It's 81 milligrams. So it really just depends on the country of origin that you come from. The largest trial of all these was the ISIS-2 trial. This came out in 1988. It decreased vascular mortality and was the major trial that solidified aspirin's role in preventing recurrent heart attacks. This is what kept into our guidelines for some time, but also asked the question of, well, if we can treat heart attacks after they happen, what about beforehand? So this was a trial from 1988. The British medical doctors, 5,000 apparently healthy doctors, came together and found no reduction in their primary prevention for aspirin. Not to be outdone, the US physicians said, well, let's put our own trial out. The year later, the US Physicians' Health study was published that did show a reduction. So why the discrepancy between the two? And this gets to the primary prevention aspect of aspirin. This was solved in 1994 by the Antiplatelet Trialist Collaboration, or ATC. This was a meta-analysis that combines all different trials, pools the patients together, comes up with a stronger recommendation for prevention with these. And in these patients, it showed that there was a reduced vascular mortality and a reduced new or MI stroke by 30% in these patients. This showed definitive evidence that aspirin's role for secondary primary prevention. They also looked at 3 trials within this, asking was there a primary prevention benefit, and it was just not quite statistically significant in this trial. So that's where we landed for years. People were taking aspirin for secondary prevention. Maybe some people were getting it for primary prevention. Then 2018 comes around, and there's 3 pivotal trials that happened in that year that really informed our current practice. The first trial is the ARRIVE trial. It was a trial of over 12,000 patients with a moderate ASCVD risk, randomized to 100 milligrams, so it was a European study, of aspirin, and they looked at a primary composite endpoint of MI, unstable angina, stroke, or death. And you can see that in the top right corner, those curves are essentially superimposed on each other. There was no benefit to aspirin over placebo in this trial. What it did notice, though, is that there was a difference in bleeding. The increased GI bleeding risk over twice for this showed that there was an increased risk of taking aspirin for this. Now, the other thing in this trial is that it predicted of those patients that it enrolled a 17% 10-year event risk, but it only observed 10%, which suggested that our risk calculators overestimated the patients that we had enrolled in these trials. The second trial in 2018 was the ASCEND trial. This was focused primarily on diabetic patients. The 3 graphs stratify the patients into low risk, intermediate risk, and high risk. And you can see that with each of the tertiles, the myocardial infarction rate drops with aspirin, but the major bleeding risk increases. And that's what the trial ultimately showed. One of the statistical features that we can use is what's called a number needed to treat. In other words, how many patients do we need to administer therapy to see that outcome? The number needed to treat for this was to prevent 1 vascular death. We had to give 91 patients aspirin. But the number needed to harm was 112. So similar, you could prevent events, but you also have the risk of bleeding. The last of the 3 trials was the ASPRI trial, the largest, 19,000 patients. This was in our older adult population over 70 years old, randomized 100 milligrams of aspirin and looked at a disabilities-free survival over 6 years. Found that there was no difference in this. Interestingly, there was an all-cause mortality increase driven by cancer-related death and an increased bleeding risk as well. Recently, this trial extended its follow-up for another 5 years and ultimately showed that there was an increased bleeding and MACE risk with this. So what changed? Why did those early trials not necessarily show a benefit? What lessened aspirin's primary prevention benefit? And that is the evolution of our medical therapy over time. We're treating patients more aggressively for cholesterol with statin use, stricter blood pressure control guidelines. We have better medications for diabetes. We have lower smoking rates. We also have risk calculator differences. We'll get into that in a little bit. And many of these trials looked at our aging population. Bleeding risk increases substantially with age, and that's something that those trials indeed showed. So where are we today? 2019 guidelines. These came out as a recommendation from the American College of Cardiology and the American Heart Association and recommended quite strongly with a decreased recommendation, class 2B, that low-dose aspirin might be considered for the primary prevention in select adults 40 to 70 who are at higher risk of ASCVD event, but not at increased bleeding. Harm, though, was noted in patients over 70 years old, so it should not be administered for primary prevention in patients over 70 years old. And anybody, regardless of age, who is at increased risk of bleeding should not be on a primary prevention aspirin. That was a pretty significant change from prior. This was confirmed by a 2024 meta-analysis from the Canadian Journal, and I think it helped kind of paint those numbers and solidify them for me. So on the left, you'll see that there was an increase benefit, about a 10% for over the trial. So if you have 1,000 patients, you're going to prevent 4 major adverse cardiac events. Those same 1,000 patients, though, you're going to have 3 that have a major bleeding event. And you're going to have 1 who has an intracranial hemorrhage. Now that worries me because the mortality of an intracranial hemorrhage is about 50%. We can fix the heart, we can fix the GI system, but the intracranial hemorrhage absolute risk is something that I think should be taken seriously. So what puts people at higher risk for bleeding or for ASCVD? We have calculators that we can use to assess this. Historically, this was the Framingham series. The MESA, the multi-ethnic atherosclerotic study, came out in 2008 that incorporated coronary artery calcium scoring. And most recently, we have the PREVENT trial, which came out in 2023. And this is actually a calculator that I use for primary prevention just about every day. It plugs in many clinical factors for patients anywhere from 30 to 79 years old, a bunch of clinical factors that can predict 10-year and 30-year risk of heart attack, stroke, or heart failure. This is a cohort of 6.5 million patients, modern medical therapy. So this is one of those risk factors that I really use to help guide that discussion with my patients about what your risk is and what we can do to optimize it. Coronary artery calcium scoring came out in the late 2000s. Like Dr. Norton showed, it's a series of CAT scans that are dedicated to look at the heart arteries themselves and can see, are there calcium in those arteries? Now, WellSpan does offer that. Typically, insurance does not approve those, but they're usually about $100, $150 for the out-of-pocket study. They do have to be ordered by a physician. These were extensively studied in the late 2000s and showed that in low and intermediate risk patients, a coronary artery calcium score of 0 predicts a less than 1 in 1,000 event rate at 5.5 years. So for the right patient in those low and intermediate risk populations, this can be a nice predictive test. Now, it's not a screening test, but it's used as a decision aid to facilitate that risk conversation. Now, we see incidental calcifications all the time. Patients get a low-dose CT scan for lung cancer screening, and we see these all the time. So they're not necessarily the same. This is a separate study that dedicates itself to the coronary arteries. There are recommendations. I apologize. This came through a little bit small for you there, but it puts cutoffs. Again, that score of 0 is reassuring. 100 is kind of the first cutoff where we start to say there's a moderate amount of coronary artery calcification. We should consider low-dose aspirin therapy for these patients. Calcium scores over 300, our guidelines recommend that those patients should be on a low-dose aspirin. Other risk factors that enhance the ASCVD risk is a family history of premature ASCVD, high cholesterol, the metabolic syndrome, including blood pressure, BMI, chronic kidney disease, chronic inflammatory conditions, which we're now recognizing plays a much larger role in these diseases. And the other one that we've recognized recently is female-specific conditions, including premature menopause and pregnancy-associated conditions, specifically preeclampsia. High-risk ethnicity and race, as well as some other biomarkers, are also risk factors that enhance those for ASCVD. Well, what about bleeding risk on the other side? Many of these are shared with the ASCVD risk. Age over 70, low platelet count, chronic kidney disease, other medications that increase that risk. This was the aspirin trial that showed that there was that 38% increase in bleeding between aspirin and placebo. So remember, these medications are not benign. So moving into our secondary prevention. Now remember, these are patients who have had an event, have had an atherosclerotic event. This is our guidelines for our acute coronary syndromes. Our default strategy on the far left is dual antiplatelet therapy for 12 months. We also have bleeding risk reductions that are well supported by our trials. We can get away with as little as 1 month of some of these medications in our high-risk bleeding populations. The one I would like to highlight is the green one in the middle, which is triple therapy. In those patients who have an anticoagulation indication, the DVT, PE that Dr. Norton mentioned, atrial fibrillation, all come with a need for anticoagulation. But that also comes with risk because if we place stents in those heart arteries, they also need to be on dual antiplatelet therapy to protect those. A couple high-powered trials showed us that it was safe to discontinue aspirin as soon as possible in these patients in as little as 1 week and continue them on a single antiplatelet agent and an oral anticoagulant. The thing that improved, though, is our technologies in the catheterization lab. Our stents got better over decades. We're now on our second generation of our drug-eluting stents. We have better medications to protect those stents. We use different techniques in the lab. We use the wrist and the arm arteries rather than the leg arteries. That significantly reduced our bleeding risk. We also have better medications. So in the chronic coronary disease, in patients who have had an event or who have a high calcium score, patients who have had a heart attack with or without stenting, chronic ischemic disease, those are the patients who we keep on either aspirin or the oral anticoagulant, depending on what they need. But the challenge I would make to the chronic coronary disease management with aspirin alone is a newer trial that came out in 2025. This is a meta-analysis of 7 randomized controlled trials comparing aspirin versus clopidogrel or Plavix head-to-head over a period of 2.3 years. And it showed that there was a reduced 14% major adverse cardiovascular or cerebrovascular event with clopidogrel versus aspirin, suggesting that clopidogrel is actually a safer medication for chronic coronary disease patients. I've tried to make a couple of these changes in my lab, in my own practice, and I think the sticking point often is, well, if patients have to have another surgery or procedure, surgeons are often a little hesitant to operate on clopidogrel versus aspirin. So we still have some work to do in that space. A couple of pearls I'll finish up with for the secondary prevention. Aspirin can be safely stopped in as little as 30 days after PCI. Triple therapy, the aspirin, the anticoagulant, and the antiplatelet agent is not appropriate for the majority of patients. Aspirin only adds risks, but does not add benefit. The direct oral anticoagulants are safer than warfarin. And if there's an anticoagulation indication, the long-term regimen should be apixaban and clopidogrel to minimize bleeding risk. For the chronic coronary disease patients, monotherapy with clopidogrel may be safer than aspirin. That's not yet been studied in the primary prevention space, but I'm optimistic we'll see some movement there as well, with the goal of keeping our patients safe. And regarding the perioperative non-cardiac surgery, aspirin alone can usually be continued. And as always, have the conversation with your doctor. If you're taking something, even over the counter, make sure you talk to your doctor about that. Because as we've seen, these have risks. So my take-home points. Aspirin's role for primary prevention is often not indicated, especially in older adults and those of higher risk. Individualize the bleeding versus ischemic risk discussion with your care team. Involve those people. An antithrombotic therapy, antiplatelets, anticoagulation, aspirin is nuanced, so have that discussion with your care team. A couple references from the primary prevention guidelines and the chronic coronary disease. Thanks. That's my email. If you have any questions, please don't hesitate to reach out. We'd be happy to field any questions you have. Thank you.
There we go. I will come around with a microphone if anyone has questions. We'll have both positions up, so either presentation or really anything that you might have questions on. Usually this is the hop and point, so. We're gonna let you guys up now, we can't let. Oh, yeah, we got some in the back. Hang on, I'll come back to you, Dr. Harvey. I'll try to move as quick as I can. There we go. There you go.
So the recommendation for a person with mechanical heart valve is taking warfarin and still taking aspirin, stopping aspirin?
Excellent question. I almost want to deflect that to our structural interventionalist in the room, but those conversations are nuanced. And yes, the anticoagulation warfarin indication should always be there for the valve itself, but it depends on the indication for the aspirin. If it's for primary prevention alone, I personally feel that comes at much higher risk with the anticoagulation on board. My personal practice for that may differ than some of my colleagues, but I would eliminate the primary prevention aspirin in that case.
Any follow-up? Are you good? Okay. Okay.
I guess that means I talk to my cardiologist.
Absolutely. Good recommendation.
Oh, okay.
So bottom line for me, there's no longer a cross-the-board generalized recommendation for aspirin now. It's case-by-case basis because the studies change from week to week, month to month. Sometimes it's good for you, it's bad for you, which is
I think a lot of that depends on the individualized discussion with the care team that knows people the best. For my own practice, if I see an otherwise healthy 75-year-old patient in clinic that's on aspirin for no good reason than just to be on aspirin to protect the heart, I feel that that comes at an increased risk, and we'll have that discussion about why I feel as a cardiologist that that should be stopped. So across the board, guidelines are guidelines, and we play within those, and it's hard to make across-the-board statements, but individualizing that care based on somebody's risk factors and bleeding risk and ischemic risk are important to have. So it's hard to say across the board, but our guidelines are very strong now, especially in patients over 70, high bleeding risk. Primary prevention aspirin comes with a lot of risk.
Okay. Oh, I see over there.
So my husband has been on a preventative aspirin for 25 years, 81 milligrams. And his new doctor said, I think you should go off. But does he just stop it? Or do you wean off of it? Or what are the long-term effects of going off?
So it can be stopped abruptly. Aspirin irreversibly binds to that one side on the platelets. The platelets last 7 to 10 days in the system. Every day the body replaces about 10% of your platelets. So a week or so, that'll be out of the body. And it can be abruptly stopped.
Dr. Harvey? Okay.
So that was great. I really appreciate that. I agree with him in that the data does change every day. It's because of the nuance of the patient populations. We're all individuals. So it was pretty clear in listening that, the kind of you divide this into those who have had an event and those who haven't had an event. And so, I have the same question every day in clinic myself. And so my question for you is, for primary prevention, somebody who hasn't had an event, which is a little bit more nebulous, it sounded like in that your first tier of thought would be risk assessment based on a CAT scan or calcium score or something like that. And so, one, is that true? And then second, if that's not true or if it's not available, then is it based on the risk calculator in your own practice? I assume from 40 to 70 with a cutoff at 70 based on the risk of bleeding, or did I interpret that right?
Absolutely right. That's kind of what within the guidelines, that 40 to 70 years. What starts the primary prevention talk for me is the other clinical factors that the patient brings to the table. Do they have chronic kidney disease? Do they have a reason for other medications? Some of those higher risk ones, ibuprofen or the anticoagulants. I don't incorporate a whole lot of coronary artery calcium scoring into my own personal practice. I see a lot of that coming from our primary care teams, and I think that's appropriate because that helps facilitate the discussion. Now, when I have that additional information, when I can flip through a CAT scan, that just is another data point to help me sway patients to or away the ischemic risk versus the bleeding risk in those patients. So I do use some of those, but I usually use more of the risk factor calculators myself rather than the coronary artery calcium scoring.
Do you have more questions?
I'm not going to let Dr. Norton. I love the discussion on the pulmonary embolism. For those of us who haven't had a pulmonary embolism and don't know of risk factors, don't have knee surgery coming up, any thoughts or things we could do just for idea of being safe or common practices and prevention, or any recommendations like that?
That's a great question. I would say immobility in my mind is probably the main thing. So if you're sitting for a long period of time, especially like maybe with your knees bent, your legs bent, sitting in an airplane, sitting in a car, every couple hours, I think it's good to get your legs moving, get your blood flowing. I think that's probably the best thing you can do to prevent from having from event. So yeah, travel would be the biggest thing, I would say, and movement. Yep, stay moving if you can.
Oh,
Yeah, exactly.
Dr. Norton, I have a follow-up.
Sure.
I'm coming from a different place, Christian, like you guys, of cardiology there. As current is not the team who usually does the thrombectomies. So this is fun and exciting that that's something interventional cardiology can offer and can do. I guess for whichever team, if you do have a PE that requires someone to go in and to remove it or to administer the VIX, what is your typical follow-up? Because you're a heart doctor and you're someone who's usually just procedures. So I usually get fielded the question of, well, who's going to manage this for me after I leave the hospital?
Yeah.
I typically tell people I don't think it's the person doing the procedure, but for you and your team here locally, what is your follow-up after the procedure? And do you usually recommend that patients get their workup or their blood thinning medications from a different team who will manage that for them long-term? Or do you assume that as part of your care model in your office?
Yep, that's a great question. Thanks for asking it. What we're doing right now in Lebanon with WellSpan is, as the cardiology team that did the procedure, we're following up with patients about 7 to 10 days after they're discharged, just to make sure that the site that we went in looks good, patients are feeling good. But that's probably going to vary dramatically. So, at the Good Sam Lebanon, we're following up like 7, 10 days after the procedure. And then we usually do an echo about 6 months or so, 3 to 6 months after the procedure, make sure their heart has normalized. But I trained at Penn State Hershey. That was not the case there. The cardiologist actually did not follow the patients afterwards. So it's just, I think it's case by case. Yeah, right now the cardiologists are following in Lebanon. But
good question. I'm here. Okay.
So the bleeding risk associated with aspirin, can you kind of specify, is that normally associated with a certain area, like the gastrointestinal tract, or is it a spontaneous thing? Does it happen because of an event? What type of risk are we talking about when we're talking about?
Great question. So the bleeding risk specifically with aspirin in most of the trials comes from the gastrointestinal tract. But those are often not as serious as some of the other ones that are noticed, like the intracranial or the brain bleeds themselves. So the risk in a couple of the trials is about 3 to 1 roughly from a GI bleed versus an intracranial bleed, but that can vary from trial to trial. It's dose dependent, so in somebody who's taking 325 milligrams of aspirin or even a gram for whatever reason a day, that's going to increase those risks of bleeding because the aspirin interacts directly with the GI tract, the stomach lining specifically. So it's mostly ulcers in the stomach that cause those bleeding events.
Good question. Another question. Oh, I got one in the back.
So I'm going to try to bring the two topics together here, guys. So, as I'm about to get on an airplane on a flight to go on a little trip, I worry about getting DVT to P. But so should I be doing anything like taking aspirin when I travel? I hear people talking about that all the time. Is that something that is studied in any meaningful way, or what are your thoughts on that?
That's a great question. To my knowledge, there are not specific trials, but remembering the mechanism of aspirin, it's different than the blood thinning type medication. So it's not going to offer you the same protection that the blood thinning type medications will. So from a prophylactic, I'm going to get on an airplane, let me take 325 of aspirin, I don't think it's going to lower your risk of PE.
yeah, I would agree.
Any other questions? Oh, any other questions? No? Okay. All right. Well, they're going to let you off the hook easy today. Let's give both of our physicians a round of applause.